Welcome to this week's episode of What in the World Is That? This week we'll be looking at endoscopes and their physics developments over time. Endoscopy is defined as the medicinal procedure that allows doctors and physicians to inspect the inside of the body and make a diagnosis or perform surgical procedures known as keyhole surgery, which I mention later on in this video. Endoscopies are performed using an endoscope, which is essentially a long, thin tube with a lens and camera at one end and either a TV monitor or eyepiece at the other, which, when inserted into the body, can perform minor surgeries and biopsies to see inside the body and make diagnoses without major invasive surgery, which is expensive, is dangerous, and much more harmful to the body than a small endoscopic procedure which usually never takes longer than an hour and has a quick recovery time. Endoscopy is now used as a blanket term for dozens of other similar surgeries performed on different areas of the body, all with slightly different scopes to effectively analyze their area. And that's what we'll be talking about this week on What in the World Is That? The idea of minimally invasive surgery has been a topic of study by many physicians throughout history, dating back as far as the ancient Egyptians, the Romans, and the Greeks, who all developed ways of curing diseases with as little disruption to the body as possible. The first modern endoscope was not like those used in BCE, however. It was simple and seems barbaric now, but revolutionary for the time. The first modern endoscope was invented first by Philip Bazzini in 1806, who called it the Lichtschalter, the light conductor. The first effective open-tube endoscope was developed in 1853 by Desmarais. This instrument was used to examine the urethra and bladder. In the late 1800s, other physicians like Kussmaul and Neitz refined the original endoscope models, and these began to be used in medical procedures. The first laparoscopy, attempted in 1901 by Georg Kelling, who called this examining procedure cilioscopy. In 1954, Harold Hopkins and his student Narinder Kapani developed a way of making pieces of glass that were flexible and could be manipulated more than the quartz or plexiglass rods. These pieces of glass became known as optical fibers, which are thicker versions of today's fiber optic cables, and were combined into bundles and used to transmit images a short distance. Following on from this, American physicist Brian O'Brien developed optical fibers with total internal reflection at a glass with transparent coating of a lower refractive index. This process prevented the total reflective surface from contamination and reduced the crosstalk between fibers. In the mid-1950s, three University of Michigan students, Basil Hershkowitz, Lawrence Curtis, and C. Wilbur Peters, used optical fiber technology to make fibers that had reduced in amplitude at 1 decibel per meter, which was perfect for medical imaging. This, along with advances in camera imaging and microscopic technology, created the endoscopes that are used today in modern hospitals. So, to summarize that section with the worldly involvement into the development of the endoscope, minimally invasive surgery was investigated in ancient Rome, Egypt, and Greece. Then, a German scientist developed the first modern endoscope, which was then further developed by an American scientist, and continued to be developed by American scientists following this. Fiber optics used to be called optical fibers, and were evolved over time, but weren't used majorly for medical imaging until an Indian physicist and a British worked specifically on flexible optical fibers that transmitted short distances. An American physicist then developed these fibers by adding a coating to the glass which improved their total internal reflection. Then 3 other American scientists created fibers whose transmitted information decayed at a rate of 1 decibel per meter, which they found perfect for medical imaging. These days, Olympus produces the most endoscopes. This company is headquartered in Japan and based worldwide in Canada, Australia, China, India, Korea, Malaysia, Singapore, Taiwan, Thailand, Vietnam, Brazil, Mexico, the US, Austria, Denmark, Finland, France, Germany, the UK, Ireland, Italy, Luxembourg, the Netherlands, Norway, Portugal, the Republic of Malta, Spain, Sweden, and Switzerland. As you can see, the evolution of the endoscope and its production and distribution in the modern world is a worldwide effort. Endoscopes treat many areas of the body, either by being inserted through an orifice like the mouth or through small surgical incisions made using a scalpel. The main reasons for an endoscopy are investigation, confirmation, and treatment, and all of these can now be done with a very high degree of certainty and accuracy. These days, doctors can diagnose, treat, and confirm many problems like ulcers or muscle spasms, things which would not be clear on other tests. As I mentioned earlier in the video, endoscopy is used as the umbrella term for many other minimally invasive surgeries. These range all around the body, and the endoscope changes slightly depending on the job it is expected to perform. Some types of endoscopes are bronchoscope, which examines lungs, colonoscope, which examines the colon or bowel, gastroscope, which examines the stomach, duodenoscope, which examines the bile duct or pancreatic duct. This procedure can sometimes be called ERCP, or endoscopic retrograde cholangiopancreatogram, hysteroscope, which examines the uterus, cystoscope and uteroscope, which examine the urinary bladder and the uterus, arthroscope, which examines the body's joints, endoscope, which examines your small intestine, laparoscope, which examines your abdominal or pelvic area, laryngoscope, which examines your larynx, mediastinoscope, which examines the area between your lungs called the mediastinum, and finally the most commonly used term, endoscopy, which examines the upper part of the gastrointestinal tract, known as the esophagogastroduodenoscopy. Endoscopes are a simple design in practice, but the theory behind it contains many physical and mechanical qualities that make it an incredibly effective tool for minimally invasive surgery. The main body of the endoscope contains the air, CO2, water and suction controls, as well as the deflection control leading off the main body towards the viewer is the main camera mount. This contains an eyepiece and lens adjustment for ultimate adjustability. On the other end is a small hole that leads into a channel for operating instruments. This channel, along with leads of fibre optic cables, the air and water channels, the control cables, and the objective lens, which all finish at the distal end of the controllable bending section of the endoscope. All makes up the shaft, which is usually only about 10 mm in diameter and can sometimes be up to 2 meters long. It is flexible and coated in steel and plastic to make it waterproof, easy to maneuver, and prevent against chemical damage. On the bottom of the main body is a channel to pump CO2 and water in and run the fibre optics through to connect a TV monitor or a recording device. The fibre optics of the endoscope make up one of the most complex pieces of technology in the tool. The endoscope typically contains 2 or 3 illumination lenses, each of which are made up of about 50,000 separate optical fibres. 1 or 2 of these cables carry light into the body, and another carries reflective light back into the physician's eyepiece or the camera. Fibre optics employ an important element of physics called total internal reflection. This is the ability for light to bounce off the walls of the fibre, providing that the walls are of a lesser reflective index than the internal fibre, and that the light rays hit these walls at a minimum angle of 82 degrees, the critical angle for light traveling from glass to plastic. The image will show clearly to the viewer. Like all medical tools, there are risks to using endoscopes. They are minor, but considerable if untreated. Some possible complications include the perforation of an organ, excessive bleeding, infection, allergic reaction to the anesthesia during the surgery, inflammation of an organ, body pain, fever, redness or swelling in the incision site. These risks vary widely between procedures. There are, of course, positives to endoscopic procedure compared to other medical procedures. Some of these positives include recovery time that is rapid at a few hours to a day or so. The alternatives can be less accurate, and abnormal results sometimes lead to an endoscopy anyway. Doctors can treat, diagnose, and observe the body through an orifice or tiny incision. Morbidity and mortality rates are very low. Most foreign bodies can be removed using an endoscopy without invasive surgery. Doctors can perform biopsies, diagnose many different illnesses, injuries, and diseases. Usually little anesthesia is needed, and there is no need to go completely unconscious for the procedure. Like I mentioned earlier in the video, surgery performed using only tiny incisions and endoscopic tools is called keyhole surgery. It involves the use of lasers with endoscopes. The lasers are useful because they can shine high-intensity light down the operating channel of the endoscope to cut or destroy tissue. The laser beams are narrow, which allow for accuracy, and the heat they produce causes tissue to seal and prevent bleeding around a cut. This can be incredibly beneficial for quick healing. Keyhole surgery has become an incredibly common technique when removing an appendix, which allows for doctors to avoid slicing open the whole stomach and leaving a large scar. Keyhole surgery provides more cosmetically pleasing incisions. The future of endoscopic technology is evolving with the improvement of microscopic technology and wireless filming. Now, pill cameras can be ingested by the body instead of inserting an endoscope to view the inside of the digestive system. This pill can then be safely excreted. As fiber optics become thinner, images gain definition, endoscopes are becoming able to capture images of the body in great detail. These are currently being developed to be incorporated with narrowband imaging to enhance the visibility of mucosal and vascular characteristics to view abnormal growths better. So, we've learnt a lot about endoscopes today. All about the history of the evolution of endoscopes and fiber optics, the way fiber optics and many different types of endoscopes work, and how endoscopic technology is bettering itself for the future. If you'd like to learn more about physical science and its involvement with medicinal science, go to What in the World is That on YouTube and watch some of our other videos.